after I came back, it kind of started up again. And I think there's something to it. And we'll just kind of go. The disclaimer is that there's not a lot of good evidence behind it at all. So it's sort of a old new technology that we're trying to figure out how to utilize. So we'll just kind of go over what's out there right now. So obviously, when it comes to neck and low back pain, axial neck and low back pain is very common. As you guys seen, if you go to any clinics, it's one of the most common reasons to present to a doc. And not only that, if you have one episode, you're pretty likely to have another episode within a year. So if you talk to the emergency room, that they see back and neck pain all the time, and certainly we see it in our clinics as well. Leading cause of disability in the Western world, and it's the second most common reason to visit the physician, and so extremely high prevalence of both chronic low back and neck pain. So the real problem is that conventional imaging is good at identifying anatomical problems. So, we can see trauma, we see fractures very easily on conventional imaging. We can see infection, obviously you can see stenosis and tumors. But you don't really see where necessarily pain is coming from. We just sort of look at the anatomy, we do a physical exam, we sort of correlate the two and kind of come up with a treatment plan. So the idea is there another imaging that can maybe show us some pathophysiologic issues that perhaps we're missing on conventional imaging? So this lack of correlation raises the question, can we do better with these patients who, in prior years, we would just sort of refer out or maybe not do anything for? Is there something that we can do to kind of further the workup? So this is a patient of mine, actually a nurse who had a ton of neck pain. And so I did x-rays, I did an MRI, and, she has some kind of mild degenerative stuff on her MRI. These end plate changes at 5/6 and see a couple of small disc herniations, but nothing sort of crazy going on. And you don't see the axials, but you should just take my word for it. Had a ton of upper cervical pain, and the story didn't sort of match with what's going on. So ended up doing a SPECT scan, and she had some pretty high uptake on the left C2-3 level, and subsequently did a facet block, which eliminated most of her symptoms. And we're still treat her non-operative. There's another patient who has previous 2 to 5 decompression, who's got pretty significant degenerative disease at 4, 5, and 5/1. Even has some modic end plate changes at 5/1 with a mild retro, some small disc herniations. And so this patient had just a ton of back pain. And so upper back pain that sort of radiated up a little bit, again, didn't quite match. And so you might convince yourself to do like an ALIF on this patient, maybe even a 5/1, maybe even a 4/1, but ended up getting a SPECT, and really it lit up at 3/4 bilateral. So that kind of shows the enthusiasm. I can feel the enthusiasm. Great.
He loves it. He's like animations. Yeah.
I'll teach you guys how to do that later. So SPECT is single photon emission computed tomography. It's founded in the 50s and 60s with widespread use in the 80s. And it's basically you inject a radioisotope into the vasculature in the 2020s. Now this is SPECT, not SPECT-CT. The difference between SPECT and SPECT-CT. So the radioisotope is basically attached to a specific ligand. There's different ones you can use, and which we'll talk about, and they can bind to different kinds of tissues. And then this is carried to different parts of the body, and then a gamma camera just picks up the emission where the higher concentrations are. When it comes to skeletal conditions, it's really this 99 technetium ethylene phosphate, which is the one that's we use, and it's specific for osteoblastic activity. So the way it's done is you go to the nuclear med, you get injected with this, you wait 2 to 3 hours, and you sit for the SPECT scan, and you get the images. And it classically shows up as this kind of like these black blobs all over a skeleton, essentially. Where the emissions are, it's indicative of amounts of blood flow and bony. So where there's high blood flow and bony turnover, you'll see these high concentrations of the radioligand. The knock on it, that's got poor spatial resolution for anatomic structures. So basically it shows that this bottom left picture where you just see sort of a black blob in the middle of a spine, and you can get a sense of where it is, but it's not totally anatomically accurate in terms of resolution. Then enters SPECT-CT, which is kind of what we're talking about. This is a hybrid imaging technique that's emerged in the 90s. And basically, you're co-registering the images. So you have a SPECT, and then you have a low-resolution CT. You combine the pictures, and you get a much higher resolution picture. So these are the pictures on the left are what you'd get from SPECT. Picture on the right is the low resolution CT scan, and you put it together, and you get a nice kind of picture in terms of what's going on with
It's like Dwayne Johnson.
emphasis. So radiation exposure, this is important. So, a conventional CT scan gives about 1 to 2 millisieverts of radiation, both in the head and neck CTs, and the chest abdomen and pelvis can be up to 20. So when it comes to SPECT-CT, the primary radiation hit is from the injection of the radioisotope. So you can see you get 3 to 4 millisieverts just from that. And then you add on a low resolution CT scan, which is about a fourth of a conventional CT. So there is, some radiation exposure that you need to be aware of and certainly consult patients on.
It's not as high as I thought it was.
Yeah, especially when
Do you know what a spine is? In millisieverts, it's to do it.
It's probably, chest and pelvis is 20, so I guess probably half of that, but I'd have to check to make sure. But you mean like a cervical thoracic?
Yeah, let's say you guys, if you got a cervical SPECT versus a cervical CT.
Yeah, so neck is 1 and
Neck is
2.
1 and 2.
Yeah.
So I imagine if it's the spine, it might be a little bit lower.
Yeah.
It's like twice. That's a lot.
So SPECT is not new to Scripps. So this is Dr. Thorne's study back in '92, where he basically used SPECT to look at upper cervical issues. So patients who presented with occipital cervical pain or occipital cervical neuralgia. He had a series of 9 patients that he reported on, which basically failed non-op management for over 2 years. And just to give you an idea of where we've come from, the picture on the left is from his paper back in the '90s. Just sort of just going on. The picture on the right is
C1 confusion.
So 4 out of 9 of his patients went on to non-op management with good or excellent results, and then 5 out of 9 went on to surgery, with most of them having good results. So he published that the C1-2 fusion can have good results when it comes to occipital cervical pain with a positive SPECT. So questions remain though. So I really try to focus in on 3 questions in terms of the data to see if we can get some better answers. And so the questions that we're looking at is, number 1, does SPECT-CT identify pain? Does it influence decision making? And how do people respond to surgery? That's really kind of what we're looking at here. So this is we'll start with the first question. So this is just a prevalence study. So this is looking at 534 patients who underwent SPECT for spine pain over 7.5 years. They had 434 patients, or 81%, had at least one positive abnormality. And by far and away, the most common places are the facet joints and the end place. And you can see the prevalence in the cervical spine in the upper 30s and lower 40s for the lumbosacral spine. So the conclusion here was that there's a high prevalence of positive SPECT-CT when you have spine pain. And that prevalence increases as you get older. You can see in the bottom right table that the percentage increases. This is a prospective comparative study looking at SPECT-CT with and without low back pain. So this was cool. They had sort of had 2 groups. They had the group 1 had chronic nonspecific low back pain, and then group 2 were patients who got scans who did not have any, this for all other reasons other than pain, spine pain. About 100 patients in each group, and they graded their hotspots as 0, 1 to 2, where 2 was a clear hotspot. And in their control group, what they found is that the odds of finding normal imaging were significantly higher, about 2 times higher in the control group. And when you looked at the hotspots alone, so the clear hotspot areas, it was the odds of having normal imaging were 7 times higher in group 1. So the conclusions were that potentially has some diagnostic workup with respect to chronic nonspecific low back pain. This is where things start to get a little bit more interesting. So this is a retrospective review of patients sent to a pain clinic for specifically for cervical facet injections. So basically, they were sent over to the pain team. Anesthesia did injections. All patients got SPECTs, but the anesthesia team did not look at the SPECT. They just injected when they thought it was clinically relevant. And they had 2 groups. Group 1, the anesthesiologist happened to give an injection where there was maximal uptake on SPECT, and group 2, it was discordant. It gave an injection where there wasn't uptake on SPECT. And what they found was that group 1 had significantly more pain relief as opposed to group 2. So this sort of suggests that if you give injections concordant to SPECT uptake, you have better pain relief, which I think is kind of interesting in this paper. This is probably the highest quality study that we had. It's a randomized controlled trial looking at 47 patients with low back pain, which were prospectively enrolled into two random groups. So it's group A and group B. So group A underwent SPECT prior to injection. And then there's sort of two subgroups. A1 received injections where they were SPECT positive, and group 2 was SPECT negative, and they were injected just clinically like group B. And group B just received injections based off of what the referring physician asked them to do.
It wasn't based off of MRI or
SPECT.
no, group B.
No,
Group A.
clinically. Yeah. I'm sure they had X-rays.
Yeah,
no other advanced imaging. So then they filled out basically pain and function questionnaire to get a sense of how they responded to that. So no difference in baseline pain scores, but group A1 had significantly greater pain improvement at 1 and 3 months, but then at 6 months, the groups sort of were equal. But interestingly, group A1 as well, the number of facet joints treated was reduced from 60 to 27. So instead of just sort of injecting kind of random facets, they specifically localized the SPECT positive. So obviously there was a decrease in the amount of injections that were performed. And interestingly, 6 out of 15 patients in group A1 had facet joints that were injected at a completely different spot than what they were referred for. So SPECT sort of highlighted an area that was not even on their radar in terms of where to inject. And then they did a cost analysis. So they looked at Medicare reimbursement, and the cost to inject 4 facet joints is about $2,300. SPECT is $800. Then if you extrapolate that out to 100 patients, you can see that there's a pretty significant cost savings as well. It's about 37 grand saved with SPECT. And so the conclusion here was SPECT-CT helped identify patients with low back pain that would benefit from injections, had better pain relief, and with a cost savings. This is a cool study that looked at basically comparing MRI findings and SPECT-CT. So they're trying to find some correlation between, is there something on MRI that we can see that would predict a positive SPECT scan? So 31 patients with severe axial low back pain underwent MRI and SPECT-CT. They basically identified 230 facets, and then they graded the facets based off of their synovial appearance. And they sort of came up with these 4 morphological patterns, which is light, mottled, narrowed, and obliterated. And I'll show you pictures of that. And they found 29 hot facets on SPECT-CT, and then they correlated that with MRI characteristics. So these are the subgroups here. So A, the top left, is sort of the light category. B is the mottled category when looking specifically at the synovium. C or 3 is narrowed, and 4 is the obliterated category. And it really was, yeah, it was this mottled appearance. Yeah. So the mottled appearance is what really correlated with positive SPECT. So perhaps something that we can look at when we're getting MRIs to sort of maybe predict where SPECT to be positive. And they look
what that bottom right, did they call that obliterated, or did they call that?
No, bottom right's different. So bottom left is obliterated. So if you look back here, it's the B picture.
Yeah.
Bottom right is a different. So they looked at facet appearance, and they found separately that this bony hook you see the arrows pointing to, that also correlated with positive SPECT. So it wasn't necessarily how big the facet got. It was this hook that formed that suggested a positive, which I've seen this before, and you may have seen it when you start to get a spondy.
Yeah.
But anyway, that's something that also correlated with positive.
That makes sense if you think about how the SPECT works.
Yeah.
Now that basically, that's why osteophytes light up, right?
Or they can light up.
Can't light up.
So cool. This, I just included this in here. This is looking at, it's another randomized control trial looking at 2 separate groups. So basically, if you have facet pain, what's a better block to do? And it's really the intra-articular block that provides better pain relief than the medial branch block. So it's something else to consider when you're sending your patients off for facet blocks. So can it ID pain? Certainly the data seems to support for facet pain specifically. Now, what about end plate pain? We don't really know. Don't have a lot of data on that. There's, this bottom right picture is this newer technique called a basivertebral ablation, which not sure yet if that's going to be something that's going to help us identify. But you can see, like the facets, they're easy to sort of diagnose in terms of correlation, so you can inject that end plate. You sort of can't do that, so it becomes a bit of a challenge.
Does anybody have more empiric experience now? I know the last time we talked about this was some months ago, just in response to how their patients have done with the BVAs. So, sorry to interrupt, Ollie.
I had two patients that I sent to Buzz for specifically for this, and haven't seen them back yet. I don't know what that means, but I should probably look them up and reach out to them.
So this sucker goes into the medical?
Yeah. Yeah, it's a probe that's sort of in there and burns.
Yeah, anecdotally, when I've met with Buzz, he's pretty enamored with it. With the right patients, it's the best procedure he does. He says
Wow.
the most impactful. So, but I think there's still some selection challenge, figuring out who
Totally.
respond.
But I mean, SPECT is probably so good at that because it identifies the end plate pain generator versus the facet. Sorry to interrupt, Ollie.
Or we hope. Yeah.
Yeah, that's the thought. I guess sort of have to prove that, but yeah.
Yeah, I you may have this in your talk, but I don't know what the correlation of SPECT is with motor change.
Yeah.
How directly they're.
But if you look at that first case example that I have, it showed some pretty significant motor end plate changes at 5-1, but
Right, that's what I mean. So that's the problem. The PVI, that is all based on motor changes, but if they are correlated with SPECT, then what utilization will SPECT? Yeah.
There's a study that looks at just that. They're highly correlated, but then you could argue what's the utility of SPECT. But anyways, I don't want to digress.
yeah, it's good. It's good talk. All right, so now let's sort of move on to influence decision making. So does it influence decision making? So this is basically a study looking at evaluating SPECT as a diagnostic tool for decision making. They did a retrospective review of patients with chronic axial back and neck pain, and they had this inclusion criteria of greater than severe pain that failed conservative management. The symptoms seemed to suggest facet arthropathy, and MRI was sort of normal. And 72 patients were included. They had positive facets in 52% of their cervical patients and about 70% of their lumbar patients. And basically the conclusion of this study, which was not sort of super valuable, was that 60% went on to a steroid injection. So it certainly influenced their decision in sending patients for a steroid injection at those areas that led up on facets. This is a retrospective review of all SPECT-CT scans in the spine, which had 212 patients. The vast majority of these specs were done for evaluation of pain. And basically, again, the most common areas of uptake were facet joints and the end plates. And they had a significant change in their treatment algorithm where they went on to conservative management 41% of the time. They had some sort of an invasive procedure 37% of the time. And a procedure was averted 15% of the time. This was our study, so Ruan's study back several years ago, which looked at SPECT and evaluated the decision making on it. So our 10 clinical vignettes were presented to 27 spine surgeons, and they sort of graded it based off of non-op pain management procedure or surgery. Then the cases were randomly reordered and represented, and then with the SPECT images to see if it would change their plan. And again, like you guys, 60% said that they did not regularly use SPECT, and 41 had lack of awareness of it altogether. But you can see the changes in pain management surgery, the non-op groups that happened, and 42% went on to a less invasive procedure, and 58 went on to a more invasive procedure. So there's something that we're getting from SPECT that's sort of changing in our mind, that's changing our decision-making algorithm, certainly. And then this I just put in, so this is our more recent study. So this was our prospective look at 110 patients in our database. And in our newer study, we had SPECT-CT was positive in 78% of our patients. It changed our diagnosis in 68% of our patients, and it changed our treatment plan 62% of the time. And then when you looked at the surgical patients, our surgical plan changed 57% of the time, with 42 having fewer levels and 15 having more levels. So again, there's something that we're getting, there's some sort of information that we're getting that's changing our mind in terms of our diagnosis and our treatment plan, certainly. but hopefully that'll be published soon. Now, the last question, do patients respond to surgery? So this is a small group of patients with upper cervical symptoms who really had no significant imaging on MRI or CT scan that had SPECT positive at C1 to C3. And then all patients had injections, but the relief was temporary, only 7 days, and all patients underwent fusion. And significant improvement in both MDI and BAS scores in the surgical group. So certainly in this group of upper cervical patients, they had a good outcome with surgical fusion. This is a retrospective review of 23 patients who underwent fusion both in the C and L spine. And in the fusion group at 3 months follow-up, 80% reported clinically significant improvement in symptoms. At 6 months follow-up, there was about half of them reported complete resolution of symptoms. And at 1 year, 82% reported significant relief of symptoms. So this was fusion basically done off of SPECT images, which both in the C and L spine, which showed some improvement. This is a bigger study, retrospective review looking at 315 patients who had surgery based off of SPECT-CT as well. And basically same criteria, chronic pain, failed non-op management, et cetera. This was their treatment algorithm. So if there was increased uptake at the facets, they offered a medial branch block or an MIS facet fusion. If they had increased uptake at the lumbar facets, they offered a pain management consult, which is a little bit of a question mark why they did that. And upper cervical or at the disc space, they offered an instrumented fusion. And so out of the 315, 48 patients underwent fusion and with significant improvements in BAS scores at 6 months follow-up. The knock on this study, though, was there's a lot of sort of negative scans. So out of the 315, 126 were negative. And so the question is here is there a lot of wasted scans being done? And how do we sort of
look at also like, I mean, I don't know your guys' VAS scores are on your patients, but like an average of 9.35, like that's almost red flaggish, right? Like, because if you think of like the ODI being in the 60s or like whatever, you're like, I'm not touching you, you know. Your ODI is like the high 40s or 50s. That's like the ideal patient, you know. Makes me wonder a little bit if their average is 9.3. Well, there's a lot of 10s and 11s, 13s in there. You know what I mean? Like, it's 13 out of 10, dog.
So
it's a great problem too, but
they do seem to respond to surgery, but we certainly need better studies. Studies are pretty low numbers and certainly need some better studies. Yeah. So limitations. So again, you got to be aware it really measures radiation from increased osteoblastic activity and blood flow. And that can be a result of arthritis at the synovial joints or some sort of pathologic process at the end. It's hard to say exactly what that is, but we certainly see, to your point, modic end plate changes versus uptake at the end plates. How do we reconcile that? So then there's this notion of hot spots on asymptomatic individuals. So the thought is that there's this sort of natural progression of arthritis where in the acute phase you get inflammation at the synovium, which can alter bony metabolism, and that's sort of where it's felt to have positive SPECT. But then sort of in this chronic phase, as the facet joint tends to sort of quote unquote burn out or maybe become spondylitic to protect itself, you can have some bony activity, but the pain is not associated with it. So we have to sort of be cautious in assuming that hot spots equal pain. It's not always the case. And certainly, if we can verify it, it'd be beneficial. And keep in mind, SPECT will be cold in any pathologic process that doesn't have increased regional blood flow, any kind of soft tissue injuries that doesn't deal with bony metabolism, other factors as well. And then I talked to our nuke med radiologist here, and there's really no standard for grading hotspots. It's just sort of subjective, but so different radiologists could have different reads in terms of what a hotspot is. And then just keep in mind,
are the hotspots truly correlated with intensity of uptake, or does it happen to be timing of scan?
we don't know.
Probably both.
Yeah, that window. You'll miss.
Right.
Because the thought is, to your point, if you wait long enough, will it eventually become cold?
Yes.
Yeah.
Right.
And
Or if you took it too early, is it,
But then, so
so the tech needed to get, to do something
But it's
else.
also relative, right? It's relative to the rest of the skeletal tissue. So I don't think it positive is a false positive, in other words. You know what I mean? Because you got that
Right.
reference.
Yeah.
Skeleton adjacent.
Yeah.
But if you
But a
got-
negative is
yeah,
not
a negative,
necessarily
it
a
could be a
negative.
misfire.
That's usually how I interpret it.
I've got, we've all got them where we're looking at something in the lumbar spine and you see the thoracic spine, there's a couple areas that light up.
Yeah.
No, thoracic spine.
Right. Right.
That,
And we passively throw that away, right?
yeah. So, yeah, exactly. So it's sort of, to your point, it's a data point. It's another tool for us to sort of, but it has to correlate. It has to correlate with symptoms. So who am I getting on? It's probably similar to who everyone's getting them on here. But it's interesting. It's sort of this dichotomy of patients. It's either the ones that have fairly normal imaging who just have chronic pain, who the MRI is pretty clean, or it's that patient who has just kind of degeneration everywhere, and you're trying to maybe perhaps localize a procedure or a surgery. You can't go into like a bigger reconstructive surgery. Then sort of, is there a role in the deformity population? There's certainly other rules that applies to fusing at the apex, et cetera, that we have to sort of reconcile as well. So conclusion, it's a tool. It's not a silver bullet. I don't think you should necessarily use it solely, but it's a tool in the grand scheme of the workup. History and physical are still important. It still has to correlate. It's an adjunct to conventional imaging in my mind, and it's best to confirm if possible. And just understand that there is a radiation exposure to the patient, and then obviously there's a cost to the system as well to be aware of. That's it. Clear as mud.
So if we take this talk and extrapolate it to what you're doing academically, should we be thinking about this in these three questions? Because like the first question seems like it has some better data, but then question 2 and 3 are lacking. Is my takeaway from.
So that's where we're sort of going with it. So ID pain, I think we have decent data on that. But yeah, can surgeries, decision making, that's our first study that we did. Hopefully we can publish that. It certainly seems to affect decision making quite a bit, at least in our set did. And does surgeries help? And that's sort of the next wave of what we're looking at to get our outcome measures based off of surgery.
Should we consider doing that with a different study design?
Which part?
The surgical piece.
I mean, in a perspective.
Yeah.
Manner.
For the clinical decision making, is that including, like you were saying, like validating after SPECT-CT? So after maybe getting a trial ticket, they saw, oh, you have multiple spondylosis, but only like L3-4 lining up, and then you get a targeted injection for 3-4. So is that including that?
Yeah.
Okay.
Yes. Yeah, have you seen our sort of form that we have?
Yeah.
So yeah, we're including even the non-op decision.
Yeah.
We're trying to capture that as well.
Right.
So that's the thought behind that. So, perhaps the idea, so you're sort of forced to make a decision without spec of what you would do. Like, maybe it's just a blanket referral to pain management. Maybe in your mind, you think it's C6-7.
Mhm.
You're sort of forced to write that down.
Mhm.
Then you get the spec scan, and then you sort of make a decision based off of new information. That includes the non-op stuff as well.
I wonder if we should
These ones.
get Buzz. I don't know if pain management has already done that, but that would be an interesting study for us to validate the disc side of things and plate side of things with the basement tumor. If he can do SPECT on the same patients as a verifier.
How hard it is to approve. I have to ask him how hard it is to approve that. But can you just do that, or do you?
Getting SPECT?
No. For the phase of the
There's a rigor to it, but I think it's aligned with the indications, which is you got to demonstrate.
Yeah.
But presuming he does that, if he's getting SPECT on all those patients, you get this additional
The only
information.
problem with that is that we're assuming modic end plate changes equals SPECT positive.
No, you do both. He's gonna have both then. The point is, the big challenge here is verification that there's a true pain source relative to the SPECT in terms of end plates, right? We can do
Yeah.
it sets, no problem. And the only way we can verify it is with surgery, which is, there's a distaste for that. Your perspective. That's
Yeah.
the harder hill to climb.
I wonder if you could look at end plate changes that were negative on SPECT versus those that were positive, and maybe do vertebral ablations on both.
Yeah.
That would be valuable. But he must be getting. It'd be good to see what his series is, because I wonder if he must be getting pain relief on just the motor end plate changes alone.
Yeah. Exactly.
So then what's the difference in pathophys?
See if SPECT is augmenting of that or discordant, But discs are weird because there's a chemical side of disc chemistry that may not have to do with the bony side.
Well, it's not, because SPECT, I don't think doesn't pick up necessarily disc end plates. Yeah. Or perhaps it's the bones reacting to what the disc is doing in a sort of indirect manner.
Yeah.
But so the spondy scenario, right, where there's a thought that those osteophytes are being created to stabilize the segment, right, to create a broader surface area, keep it from being narrow to broad. That process, I think, is what you see some of that lighting up happen. But if you go through it in detail, you realize that the highlight is not so much within the disc, it's versus that scoliosis patient you just showed there, she's banging on that one side, right? It's some kind of bony turnover happening there from probably direct insult.
We could differentiate that too eventually, down the road. The whole end plate thing, going back to the thoracic, most of the time you see thoracic stuff, it is marginal osteophyte, which is osteoblastic, right? That's almost a genetic inflammatory condition, spinal arthropathies, versus mechanical collapse and plate contact, which is a different animal, I think. You know what I mean? But helping, because that's when you present this to people, that's what they go to, like, well, but we see it where it doesn't have, there's no pain, no obvious, or not a chronic consistent.
But my answer to that would be, you see the same thing in MRIs. You see disc herniations that are there that cause no symptoms, and then you see disc herniations that are there that are significant. You can't, just because it's positive, you don't necessarily assume that it's symptomatic.
No, I know, but helping people differentiate the meaningfulness of osteoblastic activity is what I'm getting at.
Yeah.
Because I think there's probably more, there is going to be more merit to that behavior at the end plate versus at the margin of osteophytes, because it's a different pathophys.
Right.
And that's something we talk about here, but if you go out to some meeting, number one, they don't know the difference between MR SPECT and SPECT, let alone these kind of nuances to what osteoblastic activity is. And that one other point I was going to make when you were giving your talk, that not always obvious, but it'll help you eliminate some of the overutilization of stir sequences. Especially with the center arthropathy, you could see the hot facet. They don't always do stir sequences, number one. Number two, the radiologist rarely reads them as such. So look for it, and then you can avoid some of the specs to set people off from that protection. Not as helpful. Yeah.
But one of the things I think is so interesting about this whole conversation is that SPECT, unlike so many of the other technologies in spine, has evolved completely independent of industry. So there's no messaging, there's no concerted push from an outsider. It's all us internally trying to kind of figure it out. And that's kind of unique and interesting, I think.
True.